Hello, everyone. Good afternoon, and welcome to our October Partner Learning webinar. We're the folks at HealthierHere, and this webinar is PreManage Best Practices. Glad you could join us today. This is the first one in our series of Partner Learning webinars. It's just about noon. Going forward, we're planning to continue to hold these webinars noon when we can, try to make them lunch and learns, see how that timing works for us. We know it's hard to carve out time in your day, but we hope everyone at least sits down and has a cup of coffee or a cup of soup or something, and you can relax and you can join us. We have guest presenters today here from Community Psychiatric Clinic, also a representative from Collective Medical, the folks who put together PreManage. And a few housekeeping items before we get on to the formal introductions. Whoops. Here we go. Here's how we ask questions. Tavish Donahue, who is a project manager at HealthierHere, is in the room. She's going to be monitoring chat. Questions. All right. Good thing she's in the room to keep me on track. You see that little arrow next to questions? If you click on it, that opens up the questions box. That's probably the easiest way to ask questions. We'll be fielding things as we go along. We want to keep this pretty informal. You can also raise your hand. The second bit of text down is a little raise your hand box. That might be a little harder to see with this many people. We have you all muted, so it might just be a little harder for us to see the raised hand, so we're going to ask you to text in your questions. And Tavish, do you have something to add to that?
Yeah, so the next slide, we're going to talk a bit about what raise your hand will look like. If you would rather kind of speak your question rather than typing it in. And if you're logged on with your phone audio, make sure you enter the audio pin. Otherwise, I won't be able to unmute you when you raise your hand.
Okay, great.
Yeah, so typing in your questions is kind of the more foolproof.
The more foolproof way. And either Tavish will field the question or we will pause, just kind of depending on what questions come in and the pace they come in. We've blocked out 90 minutes for this webinar. We realize that's kind of a lot. We realize we might not need all 90 minutes, but we wanted to leave time for questions and to keep things rolling. If we don't use all the time, we'll just wrap up early and everyone gets a little time back in their day. We're also going to be recording the session, and we will post a PDF of the slides along with a recording on our website, so you can feel free to share this with other people in your organization. Now, quick introductions. I already introduced Tavish Donahue, one of our project managers who's here. I am Mary Megliola-Franzen. I'm also a project manager with HealthierHere. But Tavish and I are in the background. It's our guests who are doing the heavy lift today. We have two folks here from Community Psychiatric Clinic. We have Stacy Lopez. There we go. We have Stacy Lopez, who earned her MSW at the University of Washington. She has spent the majority of her career working in publicly funded mental health services in Washington State, either at the provider or at the funder level. And her title now is Director of Quality and Analytics at Community Psychiatric Clinic. We also have Nev Trakic. I hope I did it right. I'm so proud. She's the Program Manager for Mental Health Adult Outpatient Services at Community Psychiatric Clinic. She began her career in behavioral health care in 2006, received her master's in psychology from the University of Novi Sad in Serbia. She made her way to Seattle first by way of New York, and now she's in Seattle with us. And also from Collective Medical, we have Justin Keller. And Justin is a JD MPH. His title is General Manager for the Pacific Northwest for Collective Medical. In a past life, he worked with the Oregon Health Authority. Now he's focused on Oregon and Washington with PreManage work. And with that, I will hand it over to Stacy.
Great. Thank you for having us today. We are excited to be here. We're here because we were asked to share our PreManage implementation journey, and we are more than happy to do that. I feel like we should say at the very beginning, we don't feel like we are experts in the system as of yet. We still feel like we're new beginner users and that we're just really learning how to maximize the tool. So as we continue to learn, we're excited to have Justin here to help us do that. So today we're going to go through and we're going to talk about CTC's motivation and background, what got us interested in this, a little bit about what is PreManage, our implementation of the system. We're going to share some of our procedures or workflows. We'll talk about the outcomes that we have so far, and we will also touch on quality improvement and then what we're thinking about next steps should be. So what motivated us to start investigation into some sort of system that could help us was really the transformation of the system. So behavioral healthcare funding is shifting from carve-out funding through the BHOs to integrated funding through the Healthcare Authority, through the MCOs as we speak. In King County, that shift will happen January 2019, so it's really imminent. We expect this shift to have significant impact on our delivery system, and we will be expected to practice differently in ways that we're only beginning to understand. There are a few significant themes emerging. The first is integrated care. So with integrated care, the funding is shifting. So the current integrated funding model that is being implemented in January is supporting us all as we move towards practice integration. The old school disconnect between healthcare and behavioral healthcare is going away. The ACH work is helping us all identify and develop those integrated care models that will help us support our clients towards health, both mind and body. The other significant shift that we think is going to impact our work is value-based payments. Washington State needs to have 90% of state-financed healthcare contracted in a value-based payment system by 2021. And so while we don't know exactly what that will mean to us at our level, we know that we will likely be expected to create, measure, and report on outcomes, maybe in addition to process, maybe instead of, we're not sure, but do know that we will be expected to use data to demonstrate our value. So right now there are so many unknowns, but what we do know are that the Accountable Community of Health has defined measures, and those measures will include follow-up after mental health inpatient stays, follow-up after ED visits for mental health, follow-up after ED visits for substance use disorder, all-cause hospital readmission rates, and all-cause ED visit rates. So that's what we do know. And so when we look at those outcomes that we know are coming very soon, we realized we didn't have any way to track those. We didn't have any information about when our clients were in emergency rooms. We had a small subset of information about when they were admitted to a psychiatric bed and absolutely no information about when they were admitted to a medical bed. So if we were needing to participate and develop systems that were going to impact these particular measures, we first needed to know something about them. So we started to look around, and we didn't really hear about much. The option that we did hear about was collective medical. So I think Justin's going to talk a little bit about what collective medical is.
Thanks, Stacey. So for those of you who are not familiar with the collective medical platform, there's two products on the market in the state of Washington today. There's EDI, which is the Emergency Department Information Exchange, as well as PreManage. Collective Medical is a software company. We're based in Salt Lake City. Washington was the very first state where we became live with the Emergency Department Information Exchange, so that's been live in the state since 2012. Every hospital emergency room in the state is connected to EDI and is sending us real-time ED and inpatient encounter information. And that is what we leverage to provide sort of shared insights across the healthcare continuum to help people coordinate care better. So PreManage does provide real-time notifications on ED and inpatient visits to our providers in the community, to behavioral health providers, to primary care, to specialty clinics, also to our MCOs and our health plans. Anybody that has a HIPAA-compliant relationship with a group of patients can access PreManage and get these real-time insights. So this is a little bit about what kind of, this is, I joke that this is kind of a graphic about our network that doesn't really tell you anything about anything, but essentially, in short, the scope of our network is pretty broad in the state of Washington. So as I mentioned, all of the emergency rooms in the state are using EDI and are getting real-time notifications. When primary care or behavioral health that is on in the state of Washington or elsewhere in our network contributes what we call a care guideline or an insight on a patient, that information is seen by the ED provider at the point of care. And that's kind of how we're hoping to build a feedback loop and a kind of care coordination network across a broad state of Washington geography so that we can catch people in the ED and get them to where they need to be so that we can reduce overall ED utilization and also to provide just better patient care. There's better places for people to receive care than the emergency department. So we are including primary care in this. We are including behavioral health in this. I know that from the ACH perspective, behavioral health is a huge focus because of integrated managed care and we're very much a partner in that and hope to do everything we can to support that effort. We are also bringing on post-acute care, which is probably less known in the state of Washington. So we do have skilled nursing facilities that are on the network, and we are putting a lot of energy behind growing that book of business for our company. So please note that we are also including skilled nursing facilities as well. So that's really the vision, is to just create one sort of easy-to-use platform that's connecting everybody together through real-time hospital information and the opportunity to communicate back to the ED and to other users of the system on what you know about the patient, critically important information that can sort of drive better care when you're dealing with patients on the ground.
So that in and of itself, we knew virtually none of that when we started looking for a system that would help educate us about what was going on with our clients and figure out better ways to intervene. So but we had a tiny bit of information, so we started trying to get connected. What we learned is that we could purchase a connection, or there was this information out there that we could be sponsored into the system. And so we're a not-for-profit. We were very interested in being sponsored into the system because how many opportunities do you get to have a really great data system at no cost to you other than your time? So we set about trying to do that. At the time, we were working with a couple of really great folks. We had Sharon Pock, who was our practice transformation coach, and we also had Christine Stawley through the Department of Health, who was working with us on a project. And so those two were able to leverage some connections and get us connected and to a partner in Molina, and Molina graciously allowed us and sponsored us into accessing the system. So for us, that was a real win. So once we got sponsorship and started to understand what PreManage might be able to do for us in our quest to understand outcomes for our clients, this is the information that we could get. So when you sign on to PreManage, you get admission diagnosis or chief complaint, you see client demographics, you see their care team. And so this was really interesting for us because it's not your internal care team, it's a care team that might be their primary care doc, it might be their neurologist, it might be their psychologist that they get through another system. So you get to see the other people who are providing care for that client. The disposition, so you know whether they were sent home from the ED or whether they were admitted into the hospital. You also get to see their ED visit history. You can see, even though we recently started to use the system, we can see our client's history for a period of 4 years in a very easy sort of snapshot that we will show you in a little bit. You can also get reports from ED, and they write them for you in essence, and so you don't have to struggle and learn how to pull your own SQL queries out of their database or any of that. You say, here's what I would like you to do, and they will produce those reports for you. I'm not sure if that's a forever or ongoing relationship, but it works for us for now. The other question, or just as they get real-time notifications, they're able to provide us real-time notifications about clients who are hitting the system. Do you want to go back? Pardon? No, okay. That's good. So what we can also do is we can enter information into PreManage. So users, which is us, can enter what they term care guidance. So we can actually put information into the system that would be valuable information for other care providers in relation to our clients. And we can add our staff to the care team so that those other providers know that we're available as a resource for those clients as well. So that's what we learned. And so then what did that mean to us? We could be notified when one of our clients registers at an emergency department. We know why they're there. The healthcare concerns beyond psychiatric reasons. We might be able to find some of our clients who have been out of contact. For behavioral healthcare providers, this can really be an issue when people start to not do so well. We might lose track of them, but they sometimes do show up in emergency rooms, and so it's a really nice point of connection. We have actually found clients that we had lost track of. We might get new contact information. Clients are pretty good about giving updated phone numbers and addresses in emergency departments, and that's been helpful as well. We might get a new primary care provider, so we might have a new connection to coordinate care. And we could potentially use the system to communicate important information to ED providers that would result in more comprehensive coordination of care and better outcomes for our clients. I think Justin nailed it. There are much better places and ways to get care than in the emergency department. And so if we can help people stabilize fairly quickly, leave the emergency department and participate in follow-up care, it really does end up being a better outcome for our clients.
Now I can talk a little more about our protocol. It has come up. How do we actually utilize our notifications?
Keep going.
Okay. Oh, there's been a little bit of.
We had a little technical glitch. My apologies.
Okay, no worries. So when my clinicians get notification from PreManage that our client is in ED, we decided to look into what is the concern. Was that psychiatric concern or medical concern? And that's how we decided to divide the task. So if we are looking on the last psychiatric concern, clinician get notification, they'll log in into PreManage for details. And if there's a request for visit to the ED department for the assessment, we then follow our protocol that we have at the agency. We go to the ED and assess the client, and based on the assessments, we update the crisis plan and treatment plan. We talk to our supervisor, bring up clients for discussion with the supervisor or our interdisciplinary team. If details from the ED visit tells us that the client was there briefly and was discharged, which we would have that information in the notification, actually after the login to the PreManage, then clinician would outreach to the client within 2 business days, and either in person or phone call would be just fine. And based on the outcome of that visit, we would again update the crisis plan, treatment plan, use all other steps as previous scenario, and just follow the guidelines as we did for previous case. If we had medical concerns, the client had medical concern, clinician would again log into PreManage for details. We would contact clients to talk about what brought them to ED. We would discuss how clients could access primary care provider within the next 3 business days, and we would coach them on discharge follow-up. And at the same time, we would consult with our CPC medical team, add diagnosis if there was diagnosis to add medical records, and as well as follow-up as needed.
Okay, so yeah, Nev, some people are having trouble hearing, so I'm just moving the mic closer to you.
Okay, that's a good feedback.
Yes. So I want to take us back because this is a workflow that we developed in response to the notifications, but I want to take us back a little bit to talk about our process before we got to the development of this particular workflow. So once we understood what the system was, we created a core implementation team, and we had both data and clinical folks at the table to work with PreManage staff, and we also had assistance from Christine Stolle at DOH to facilitate things and help us not only determine our workflows, but to record them and make sense of them. So we got that group together. The first thing we had to decide was how we were going to access the information. So that's what led to this. Our choices were interesting. This is a system by which you basically sign on via a 2-factor authentication process. It's just a system you can reach into and look at data at any particular time. So that was an option for us. We could have just opted to have access into the system where we could, on an ad hoc basis, go in and check for any individual client or look at some of our aggregate measures. The other option was they could do push notifications to us. So a push notification, what that looks like from our perspective is it's an email to the staff that we have designated to be associated with that client. So the email doesn't say, Nev is in the emergency department. It says you have a PreManage notification. So if you get a push notification, you then need to go and sign on to the system, and you'll get the particular detail about what client is in what emergency room and what the presenting problem is, to give you a better opportunity to determine which of these workflows you're going to follow. So once we decided, Nev brought together a team and talked about it, and our clinicians were really very interested in receiving these push notifications because they felt like it would improve their ability to intervene with clients in real time and provide that really immediate support. I hear questions all the time about how did you get your clinicians to do that because it's more work. And I'm fascinated by that question because from our perspective, our clinicians were eager to get this information.
Yeah, we did not have much, I did not have much problem motivating my team. After presentation and very soon after they started using this system, they were thrilled. So much data available to them. I mean, I can say that even our clinicians are data nerds in that sense. There's a lot of information, especially for this resource when clients are in ER, inpatient, especially for medical purposes. So this is very, very helpful. And it was really not hard to motivate. They were just thrilled and to the date. And we are using this system now a year and a half, or even longer.
About a year. Yeah. So once we decided how we wanted those notifications to flow, then we had a little technical work to do. So we had some technical folks on our work group. And the way that you associate your clients with your agency and your clinicians in PreManage, and Justin's probably going to help me if I get this wrong, but you create a flat file and you send that to PreManage. So you need to decide how you associate people, and you need to decide the frequency with which you're going to do this association. And that frequency would hinge on how often you get new clients, how often staff changes, and they need to be associated with different clients or different staffs, how often clients leave, so they're no longer associated with your agency. We settled initially looking at workload and information flow. We settled on a once-a-month file transfer. So once a month, we send PreManage a file that says, here are our clients, and here are the staff they are associated with. And then PreManage uses that to do these links for these push notifications. So when the client is when Nev's list of clients, if one of them show up in the ED, then Nev is the one who gets the notification. Yes.
I'll just add on to what Stacy just described. So not every organization needs to use real-time notifications. Not every organization is resourced the same way in terms of providing us a file that includes provider assignment. It's not required to use the system. As Stacy mentioned, you can log in at any time, look at the information. You can have a single staff person triage all notifications if you want to send those, point those in a singular direction. You can also consume the information in report form. So instead of looking at real-time notifications, if you want a 30-day look back or something else, and that's what you have the capacity to do, we can do that as well. So we tried to make the system as flexible as possible. The only requirement on the eligibility file side is your patient or client list and the patient identifiers that we need to ensure that the John Doe that you have as a client is the same John Doe that we have in our system. So everything else related to provider assignments and real-time notifications is optional and totally up to you as an organization.
Got the next one? Yes, please. So that brings us back to.
We need to, yeah, just bear with us.
Sorry about that.
Yeah, technical snafu.
Now we have a new slide. There we go. So that brings us back to our workflows.
So now you have actually a framework. How did we come up with a flow for our notifications? So I talked a little bit about ED protocol for notifications, and then you got a framework for that. How did we come up with that? And now this is inpatient notification protocol. So when we get notification for clients who are in inpatient hospitals, we again decided to base it on concern. If it's a psychiatric concern, clinician gets notification, they log in with PreManage for details, they follow the same existing protocols for that we created for inpatient admission. We coordinate care and prepare for discharge for the client. If there is a medical concern for the client being hospitalized, same with clinician login into PreManage for details. We update the analysis in the medical records because that's very important for us to track. We request records as necessary, reach out to the client for support and follow-up care, and we coordinate care with other providers in that facility as necessary and as needed.
So now what you're seeing is a snapshot of what you see when you look into the system. So this is when you receive a notification and you go sign on to PreManage, this is what you see.
So in the left corner, upper left corner, you will see client's name, date of birth, and then now we have these blackout boxes. You would also get information, client's ID number, so your agency ID number would be there, one of the boxes, phone number and address the client gave when he or she or client, yes, that's exactly where the cursor is, would be what they provided at visit, ED visit, which is very important to look at your records for potential updates. Sometimes when you have hard time accessing clients, that might be the most recent information that they provided. And one of the boxes, yes, that below box would be who is attending clinician for that client.
So I'm gonna that where it says tags right there that they're pointing at. That is where you would see the clinician that we sent to PreManage to associate with this client. So that's where that's where it would say Stacy Lopez if I was the person who was the clinician assigned to this client.
In the upper right corner would be care providers. You usually see primary care providers, and that's very useful to update in our system, especially if client seeing somebody currently, and we can coordinate care. If we look
I'll pause you there, Nev, just because I want to talk about the care provider box briefly. So the care provider box, if you notice, there's some information in there that might not be the most accurate or current. We've been hard at work on that section for 2 years, and probably before the end of the year, don't quote me on it, but around the middle of November, we will be launching what we call Care Team, which is going to replace care providers. And what it's going to do, it's going to be the interface will look a little different, so it's going to be a little bit cleaner. It'll give you the source of the information. So did it come to us from a payer? Did it come to us from a primary care provider? Was it manually entered? Did it come to us from a hospital, a ADT feed? So that you can make better educated guesses about how accurate you think the information is. And it's also going to allow you to filter the information and remove historical information that's old, et cetera, et cetera. So we're hoping that with the launch of Care Team imminently, that section becomes much more valuable to you.
which is very useful.
Yep. This is also where you can add yourself as a provider so that you are up there in the group, so that if anyone else is looking at this client's file who is associated with this client, they will see that you are associated with this client and could potentially reach out to you to coordinate care as well.
And Stacey, a quick question. These little X's up here, sorry, I'm trying to make the cursor work. That means I can delete a provider? Or I can edit? Is that what the
That is correct. You
okay.
you can edit provider information. So and that will be true for Care Team as well. The Care Team, when it comes out, it will, for all of the automated feeds that we're getting and all of the eligibility files that we're getting, this information will be governed by NPI numbers for those that have one. And so we know with NPI, there's sometimes inaccuracies on contact information, and we also have providers that don't have NPIs. So there will still be the ability to edit that information, update a phone number for a care provider if you want to be in Care Team. The vision for Care Team over time is that it will be the one-stop shop of if you need to do a case conference or something on a patient, you know exactly who you need to contact, who touches that patient, who can be part of that group. It will take a couple iterations to get there. So for now, this information can be edited and deleted by other people within that organization.
Thank you.
Yep.
So moving on to the central area of this
patient record.
Yeah, patient record. Thank you for helping me with finding words with it. So this is actually the crucial part of this record. Tells us the most recent visit and encounter data would tell you the date. So actually encounter date would tell you when client was admitted, what type, the location and type of the visit. This client was most recently in a UW Medical Center emergency visit, and what was a chief complaint. So it would be psychiatric or medical. And if you click on the encounter data, not right now, it's again blacked out, but usually it's a blue link you can click on, and it takes you to a new page, actually
pop-up window.
Pop-up window that gives you more details of that visit. For example, who is attending practitioner, maybe a discharge date, more information about chief complaint, if client was maybe from emergency room located to inpatient, and etc.
Okay. So, yeah, I'm going to interrupt briefly. We've got a question from the audience. What happens when another provider or your organization enters incorrect information in the care provider's box?
It's a great question. So this is where I think part of this system is the flexibility of using it, and part of the concern of a flexible system is that it requires a little bit of policy and a little bit of protocol, as being demonstrated now by Nev and Stacy, about how to use it. So I would encourage each organization who's using our system to think about how are you going to govern content creation? Who has the ability to edit or change information in the care team section? Who has the authority or ability to enter care guidelines? And what are your goals and sort of the structure around what that looks like? So that's something that our team tries to help people with, but obviously as the IT vendor, we're not experts of this. So that's why we turn to our colleagues to kind of demonstrate what they've done and try to share best practices. So it's a great question. And I think within members of the same organization, there's nothing to prevent people from putting in incorrect information. So I would encourage people to think about that from a policy perspective within their organization. And then I think the other level to that is that I think as communities, there is also a vested interest by the ACH and by all of our partners to sort of say, we really want to keep that care team information accurate across the community, so that if there is a high utilizer group meeting and people need to come together to case conference on a particular person who's at risk in that community, that information is accurate and up to date. So hopefully there will be organization level efforts and then community level efforts to help govern that information and keep it accurate.
Next slide.
So before next slide, we just want to make sure that we follow the story. So if you look at show encounter summary graphs, that's actually the next slide. Very useful information. It tracks visits, ED visits or hospitalization visits. We have access to last 4 years of encounters, and I really find this very useful because it can tell you a story, what is happening with the client for a period of time, and we can go back and look at the client's data in the chart and help us understand what led to increase of hospitalization or decrease, so we can help us with stabilization of clients. So this is very useful information.
I want to pause here because if you look at this graph, I'm assuming this is like real client data.
Yes.
So you notice, you can see the different hospitals that this person has visited, and some of them are not in Washington. Some of them are actually in Oregon, in Portland. So that's another thing that's important to note about this system. This is one open network across every hospital that's contributing data to us. And so because we have the entire state of Oregon on the system, because we have other states like Alaska and Idaho and California coming onto the network, as you have a client who is on vacation or is also just maybe they're housing insecure and they're going up and down the I-5 corridor, you will see that information in the system.
This is yet another view that is easily accessible in the system. So as you can see, you can choose a time frame. And the concept in PreManage is you look at information via cohorts. So you can identify a cohort by your own parameters, or they have a lot of cohorts that are already identified that they track. So these are a couple different measures of different cohorts that are standard in the system. So you can do last 24 hours, you can do last week, you can do last month, and it just lets you look at what is going on with your client cohort. So if you are actively trying to manage this outcome on a systemic level or an organizational level, this is a great way to just track your progress very easily. This is one more system view. This is sort of a daily look, and this tells you client by client what happened over the last 24 hours. So if you were trying to manage, from a crisis intervention standpoint or actively manage to this level, you can go look and you could arrange follow-up visits from this. So if you were to choose a more centralized system of monitoring this information, you could look at it from this view and deploy resources.
We call this our census page. So every PreManage portal has an ability to just look at your entire census, which instead of focusing on specific categories of risk is just looking at every ED encounter and or every inpatient encounter across your entire population. And it will give you both a trend of what that's looking like, as well as it shows here, a list of the specific patients that have had those visits. And you can quickly link to their patient record from this page.
So this was one of the things that we put together for our organization, just using data from PreManage. We're just looking at very rough measures at this point. We're looking at ED visits per month, total ED visits, and then unique number of clients. We are starting to look underneath this very rough measure. And when we look at this, we had not fully implemented PreManage until maybe January, but because we can look back, we definitely can see what's been going on with our clients over time. So there's a slight downward trend, and we have lots of folks who clearly go to the ED more than once, right? So the next slide.
So next slide came from a meeting I had with Christine Scally, our DHO consultant, that I met with her at the beginning of this year to see where we are with implementation of PreManage and where we want to go now that we started to implement PreManage and what is our vision. So she gave us an idea to come up with a list of 5 or 6 most top 6 visits. What is the reason why people go to the ER? And that's what we did. We looked at January visits. There were 370 visits, but half of those did not have reason. We could not find reasons. So from others, the rest of it, this is what we were able to find. So from top 6, 4 was medical reasons for visits, and pain. First 2 were pain reasons. Pain was a reason. Chest pain, cellulitis, and then last 2 were psychiatric reasons. So that started to inform us in which direction we want to go.
So I think, to me, if you look at that last slide, there's nothing surprising there that your average ED physician couldn't tell you. And so people are in the ED because they have pain. That's not too surprising. So this is just one of the things that we have been able to learn, right? We are just newbies to this information. We're learning what's in there and what's going on with our clients and why they're showing up.
Okay. So we've got another question from our audience. Yeah, Justin, I'm going to direct this to you. What is your suggestion for agencies who are having difficulty being sponsored into PreManage?
That's a great question. So if you can talk to your MCOs about being sponsored, that's probably the first course of action. If you're struggling through that, you should probably reach out to your ACH contact. We are working very closely with some of our ACHs, particularly here in King County, and they can help with that. You can also just reach out to me if you really want to. My email is justin.keller@collectivemedical.com. I'm sure the HealthierHere colleagues can forward that to the group after the meeting, and we'll see what we can do. I will say that for organizations that are sponsored and are coming on at no cost, we encourage everyone to reach out and join the network. We do have a limit, I have limited resources in terms of bringing everybody on at once. And so I'm really turning to my MCO and ACH colleagues to help us understand which organizations should be prioritized. And really what that comes down to, and the reason why it's so great to have Nev and Stacy share, is because as they're articulating to you, they came up with a process and they prepared for how they were going to implement this system. And our goal in bringing organizations onto this tool is that you're successful immediately out of the gate. And in order to do that, it does require some planning. We need to make sure that we have a clinical contact. We need to make sure that we have an IT contact. We need to make sure that you have the resources available to you to create an eligibility file and update it on a regular basis so that when you're using the system, you are successful right out of the gate. So those are kind of the three approaches I would take. If you're interested in getting this system, start with MCOs. If you're struggling through that, try the ACH. And if you're struggling with both, please contact me directly.
Thank you, Justin. And I just chatted out your email address.
Perfect, thank you.
So everyone has access to that. We did get another question, more for our CPC folks. Did you say that half of your visits were not associated with a reason for visit?
And that's actually related to data quality. So just again, all of the encounter information that's coming to us is coming through what we call admit discharge transfer feeds, or ADT feeds. And these are standardized messages that are coming from every electronic medical record in existence. So every hospital is just generating these messages and sending them to us in real time over the course of a patient's encounter. So as they're registered in the ED, as they're transferred or admitted to inpatient, as they're discharged from the hospital, from wherever stage they are in their visit, we're getting those messages, and we're doing our best to clean that information and curate it and then provide it to you. And sometimes those messages don't have a diagnosis associated with them, or they don't have a chief complaint. When we have a specific hospital where we notice there's a trend where maybe a hospital is never giving us diagnosis, we're doing our best as a vendor to reach out to that organization and say, hey, we would really love it if we could get diagnosis from your facility. But that's an ongoing body of work that we're doing. So we don't always get diagnosis, unfortunately. We share whatever we have. So if we have it, you're seeing it. And if you notice trends there and you're really concerned about a local hospital that you work with not sharing diagnosis information with us, please let me know. We have a quality process that we will go through to try to get that information added.
From an implementation perspective, we have approached this, it's an iterative process. For us, the leap forward and having the majority of this information, it puts us so much further ahead in our process that when we are missing data, if half of the visits don't have that, while it would be lovely if 100% of the visits had the diagnostic information, just knowing the visit happened for us is great progress.
I think it was less than half.
Okay.
That's good to hear.
Yeah. This next one that's up on the screen is another way to look at the data, just ED visits per month by program. So what we did is we split it out on our programs, and what we looked at was what number of these visits were occurring because we had clients with 5+ visits in the ED that month. When we were looking at how do we begin to impact utilization and provide better care for clients, of course, we have a lot of clients and you can't effectively intervene with anyone, but it seemed as if clients who are using the ED very frequently would be a natural target for intervention. So it's very easy to identify who those are, and when you look at the numbers, it's clearly our next step. So we are in the process now. We were just talking with Justin about implementing care guidance. So when we started this journey, we very deliberately did not have our clinicians entering care guidance, and it was because we didn't have policies and procedures governing that activity, and we just didn't feel like we knew enough yet to do that, because we didn't want to be entering things that were irrelevant or inappropriate in the record. And so we are just now in the process of working towards getting care guidance entered for our clients who are high utilizers of emergency rooms. And we have talked about that, and Justin actually agreed to share with us some best practices that someone in Oregon developed. So we're looking forward to that being our next step. So this is just a story, right? Like, why does this make a difference in our practice? So a client called her clinician at, after hours on a Friday, saying she was suicidal and had overdosed. So the clinician and the supervisor called 911, but in the old days, we wouldn't have any way of really knowing what happened after that, which ED she went to. We wouldn't have had any way to provide relevant information to them. But in our new world, we got a notification at 5:17 she was registered in ED. Like, boom, she was there. And so not only did we know she was safe, but we were able to reach out and share pertinent information that could aid in both the assessment of the current situation and information to support the development of a safety plan. So for us, that's the difference, right? We just have information and knowledge that we didn't used to have that allows us to be more effective with our clients. So what have we learned? We developed a more comprehensive understanding of our clients' health. Again, the healthcare, in behavioral health, we have not always attended to the whole person, and so frequently we had client records that didn't contain any diagnoses about their physical health. And we've really been working on that, because in order to treat a person, you need to really understand their concerns from a holistic perspective. So now we have this influx of information about our clients' physical health. So that's helpful to us. It has strengthened our relationships with ED providers, right? We are able to be more responsive because we know what's going on. We frankly learned just how frequently our clients are showing up in the ED. That was huge news to us. We had no idea how often our clients were in the emergency room. And where they were. And just knowing that gives us a lot of information that we will be able to use to figure out how to improve their ability to connect with primary care or ongoing care in the community that is not based in an ED, because it's expensive and it's not the best place for them to get care. So we have learned that we think we're ready to take some next steps. And our next steps are we want to continue to increase our ability to analyze the data. There's a lot out there that we haven't been able to look at yet. We want to more actively participate in the PreManage user group. They have folks from both sides, right? They have hospitals and emergency departments that are participating. And so to really develop that understanding about what is useful from their perspective and how we can participate and be a better partner in this is going to be very helpful to us.
And I'll pause there and just kind of explain that there's been a monthly PreManage user group that I posted in Washington since January of last year. What's been exciting about watching that group evolve is I think now with the engagement of our ACH colleagues, we have an opportunity to have a couple of layers to that. So it could be that in the future that there's actually user groups happening at a community level where the ACHs are helping us convene those discussions, and then there will continue to probably be a statewide group that's probably going to shift and focus next year to more of best practices for how to support a network, a local community network. So I'm very excited about kind of the opportunities we have with partnering with our MCOs and ACHs and all of our customers in 2019.
So we also want to develop a standard set of interventions for high utilizers. That's a goal. We aren't sure how that will play out, but that's a goal. We want to continue to develop or strengthen relationships with primary care providers, because that is how we will help people not use the emergency room department, is that they will learn to be connected with their primary care physician and get care there. And we want to develop standard protocol and resources for education on ED alternatives with our clients. So, just teaching people about nurse lines or urgent care alternatives, going to your PCP. So we still have a lot of work to do. Happy to take any questions that are out there.
Well, so let me jump in. I know Tavish is assembling questions again. I just want to say thank you very, very much to Nev and to Stacy and to to Justin, and I think there's probably a whole lot of questions coming your way, but just wanted to pause and say thanks so much. So it's very informative and very well organized.
Thank you all. And for our first question, we have Dr. Dan Lessler, who's HealthierHere's Chief Medical Officer. So Dan and Melissa, I'm going to unmute your line now. They were at a committee meeting that just wrapped up.
Yeah,
Dan, are you on the line?
Yeah, can you hear me?
We can.
Great. So great presentation and really awesome work in terms of how the PreManage is being deployed. I actually I had two questions and one sort of for whomever, and then one I think specifically for Justin. But Justin, you might want to comment on both. First is I'm wondering, are you making, and maybe I missed this because we missed just the first couple of minutes, but are you in any way making use of the care plan functionality that exists in PreManage, either in terms of viewing care plans that have been put in by others or modifying and putting in plans yourselves? That's the first question. And then the second question actually is more directed at Justin. Justin, I know that or my understanding is that Collective Medical should be getting the full Medicaid claims data to be able to work with, and I particularly with respect to diagnostic information and knowing that ADT information, I mean it's better than nothing, but it's subject to a higher degree of inaccuracy even than claims data in some respects. And I'm wondering if there's any thought about enhancing diagnostic information through PreManage with what you have available in claims data. So those are the two questions. One, are in terms of CPC, are you making use of care plans in any way, and then how claims data might be used to enhance diagnostic information?
So if I understand correctly, the care plan translates in PreManage to the care guidance section.
Yes.
So that is where we very deliberately did not engage initially because we weren't sure how to use it appropriately. So that's our next step that we've identified, is to really fully implement a policy and procedure. And we are starting with our high utilizers. So anyone who's had 5 or more ED visits, we're getting our clinicians to put care guidance in. But we've wanted to be very careful because we want to put things that will be helpful to emergency rooms and physicians in there. So we've been waiting to do some more learning about that, and I think we are poised and ready to move forward.
Yeah, we are not putting our own care guidelines, but we are happily utilizing other providers' guidelines, and I think they are very helpful if we see guidelines from UW or ER, Harbor or any other provider that's in there. That's very helpful for us to know and be oriented how to work with the client.
And then Dan, to your other question about claims, it's an excellent question. So for those of you who weren't aware of this, so our system was built on kind of hospital ADT, but as a technology solution, we can consume any kind of data available. And so in partnership with the Healthcare Authority, we recently were able to start getting Medicaid claims data. So from the state, we will get the fee-for-service Medicaid population, and then as part of the contracts between the state and the MCOs are now required to give us claims data on a monthly cadence. And you're correct, Dan, that we started getting that claims data at the end of summer. So we're still working through some of the kinks about making sure the data is clean and consistent from the MCOs. And then probably starting next quarter, you will probably start to hear from me about some of the efforts we'll be taking to both make our existing data cleaner, because we have claims data. So obviously there's a lag, but if you're thinking retrospectively about ED visits or inpatient stays and why someone was there, eventually those kind of ADT-based diagnosis and chief complaints will be replaced by more robust claims-based information around this was the diagnosis that was tied to this event. And then because we're getting all claims, I think all claims, you'll start to see additional functionality that has not been available because of the limitations of ADT. So down the road, you might see things like medications that are coming from the pharmacy claims that we're getting from MCOs, et cetera. So absolutely, we do need some time to sort of do research and development on the claims data set. This is the first time we've gotten a full claims data set from a state, but we will definitely be looking to make quick advantage of some of that so that we can start to solve some of these problems we've heard from our ambulatory providers from some time, which is if you're trying to do discharge planning because you know someone's in an inpatient, encounter right now, you need to know the meds that they've been on. You need to know discharge summary information. So we're trying to do our best to build the system from what we've already got. Does that help?
Yeah, Justin, that's terrific. Just really great to hear that. One thing relative to the conversation, we just had around the identification of providers, and the fact, somebody brought up, what if that information is incorrect or incomplete? I also wanted to specifically call out, as you guys are looking with claims at what you can do, and you've mentioned, several important things, is that the ability just to say, give sort of like a 3-month time frame and say, just list the providers that actually were seen, can be very helpful. That it provides validating information that you might have 3 PCPs listed, but you look at the last 3-4 months and you see this person's primarily seeing Dr. Smith. So anyway, it's great, and I just wanted to call that out because it tied back to the conversation.
I appreciate it, Dan, and you're absolutely right. I think there's so many aspects of what we're doing today that would be improved by this data. So we're very, very excited and very, frankly, honored that the Healthcare Authority agreed to, partner with us to get that information flowing.
Do we have more questions coming into
us? We do. Yeah, we have a question. Is there a cost associated with contacting or working with you, Justin?
I charge $500 an hour. No, there's absolutely no cost associated with. Please do reach out to me. I am a busy individual and I travel a lot, but don't be afraid to contact me. You can also contact support at collectivemedical.com, whether you're a customer or not, and those things will be triaged to where they need to go. So sometimes those things will be forwarded to me. If I can be the best person to answer that question.
Yeah, I'm sending out that email address to everybody now.
Thank you.
Oh, I can imagine your inbox. Yeah.
Okay.
I'm fine with it.
Yeah, and no other questions have come in.
Okay.
Yeah, if you'd like to speak your question, please go ahead and raise your hand. If there's any questions or comments.
While we're waiting, I'll make a plug for our next partner learning webinar. We have one coming up on December 5th. Once again, we're doing it midday. Hope the lunch hour works for folks. If you have strong opinions one way or another, please let us know. We can always move the time of things and adjust going forward. Next time is about registries, empanelment and registries, a population health perspective. And our presenters will be Dr. Jeff Hummel of Qualis Health and Michelle Glatt, who is the Vice President of Population Health at HealthPoint. Any questions before I go to my very last slide?
Nothing has come through.
All right, well, please stay in touch, stay updated. We are going to share the slide deck and the recording. Here's where you'll be able to find it. You can nose around our website and find plenty of information, and also the general HealthierHere.org. Sign up for the newsletter, and that will keep you informed.
Yes, and I noticed we had a lot of new names on the line today, which is fantastic. So if you were forwarded, the information about the webinar, you're probably not on our main email list. So I would strongly encourage you to go to our website, sign up for the newsletter, and that way you will be in our database and you'll get notifications about future webinars.
Great. And again, thank you everyone for joining us today and the great questions and for sticking with us. And thank you to Nev and Stacy and Justin. This information is great. I think you're all going to be hearing from people once we wrap up. And I guess we came in just about at the 60-minute mark, unless we have any more questions, Tavish. One last call?
Nothing has come through.
All right. Well, thank you all very much, and have a good afternoon.
Thank you.
Thank you.